Please rise. Please be seated.
Well, thank you all for coming. I've always wanted to be the man who needs no introduction, so finally I can tick that off my list. I guess you probably know who I am, because otherwise you wouldn't be here, so thank you all for coming. I'd like to particularly thank the Pro-Vice-Chancellor, members of the party, other members of the Oxford administration. I'd like to thank the department, head of the department, family who've come from as broad as Boston and Scotland. At least one of the Scots you'll be able to recognize fairly easily. Friends, neighbors, and colleagues from our department and beyond. I'd also like to thank the Mathematics Institute for hosting us, and the principal of Green Templeton for hosting us for the reception afterwards, which I'm sure you're all dying to get to, so I'll be as quick as I can. And most of all, thank the staff who've put this event together and invited you all and made sure we all got to the right place at the right time. So one of the advantages of this format, in addition to not requiring an introduction, is that there's no questions at the end. The first lecture I gave in Oxford, Dave Foreman was my host, and I was grilled by the two Richards at the end of the talk. So this gives me a little liberty to perhaps think a little bit bigger and broader than I normally would in giving an academic presentation. And you can grill me over the reception, but at least I won't be challenged on the spot. And so what I've done is to think about a little bit of the history of how we got here, particularly with prospective cohort studies, and where we might go next, particularly in the United Kingdom. So the title of the talk is Big Epidemiology Better Epidemiology? And I hope by the end we'll have at least reached an approximation of that answer. I'll be talking about the sort of classic principles of breadth versus depth in study design. Talking a little bit about some experience with the genome-wide association studies. Introduce something I'm calling rather probably too grandly systems epidemiology, but really the idea is to integrate epidemiology into the system. And then maybe a little bit of iconoclasm at the end, talking about what could be a virtuous cycle by which we are able to do even more than we've already done as epidemiologists to contribute to the nation and world's health. So breadth versus depth invites the question, small studies or big studies? And I think it's very important to point out that there are occasions when the smallest of studies can be illuminating and essentially give us all the information we need. So of course, classically, James Lind, people call it the first randomized trial. He randomized 12 sailors with scurvy to 6 different diets, and it was the 2 sailors with citrus exposure that rapidly got better, and that changed life for the Royal Navy and beyond. Within about, I think, 200 yards of where we sit, there was the famous example of the Oxford policeman who had septicemia, galloping infection, and was given the first treatment of penicillin that was available through Florey and the Department of Pathology. He rapidly got better. Unfortunately, they ran out of penicillin before he was completely better, and when they ran out, he unfortunately died. He must have been perhaps the first N of 1 experiment, but sometimes you don't need a whole lot of data to be convincing. Professor Terry Dwyer is here, and based on data from 15 infants who'd experienced sudden infant death syndrome. When I was a medical student, this was a total mystery. And based on that number, he was able to conclude that the prone sleeping position was a major risk factor for SIDS. And so all of us who subsequently went on to have children later carefully chalked them on their side so they weren't sleeping on their fronts, and the incidence of SIDS has declined dramatically. Incidentally, I think Terry only dimly remembers, but he was kind enough to take a call and then a meeting with a hospital resident in Sydney when he was an associate professor at the University of Sydney, and he was largely responsible for telling me how you got into academic public health. It was at that time. I hadn't sort of quite worked out that epidemiology was going to be the right part of public health. So in a way, if you actually don't like the lecture, you can take it out on Terry. Having said that, then, you know, there is this competition. Some of you will be old enough to remember this TV series, and we've been sort of yin-yanging back and forth for a long time, particularly in the last century. Quality versus quantity in epidemiology. Some people argued that we're okay to be small, but we should be really deep, careful, considered, take the best measurements we could possibly take. And if you're doing that, and you're seeing people regularly and doing all sorts of tests with them, you're not going to be able to do that for a lot of people. So in my neck of the woods in Boston, the Framingham Heart Study was always the example. And being small and deep, fabulous findings from the Framingham Heart Study. That's led to the work on lipids and statins. That is one of the reasons the Nuffield Department of Population Health is famous. But for something like cancer, they've made very, very little contribution because with 5,000 people followed, even for a very long time, there's relatively few numbers of cancers that are individually quite rare on a site-specific basis. The alternative, of course, represented by studies like the Nurses' Health Study that I worked on for 20 or 25 years, is to be large, get adequate numbers, get big numbers, but that meant that we were limited to initially data we could gather on questionnaires and subsequently data we could gather through blood samples from a fraction of the overall cohort. So there are still people who argue this back and forth, and it really comes down to horses for courses. There'll be times when small is beautiful. There'll be times when we really need the power of large studies. The paper that really influenced me and made me understand the power of large studies was, well, before I do that, basically one of the problems we've had is that small has often meant that we've done underpowered studies, we've often been under pressure to publish, and so the public gets very confused when we appear to be changing our advice, and that's all being contributed to by the fascination the public has in the work we do, how to prevent disease, which has meant that almost literally every day the newspapers, now that social media, have to find something that's been recently published to talk about. And so the small studies, extensively mined, have led to a lot of heterogeneity in the conclusions, which has given people the impression that we don't know what we're doing. And so the large studies, more stable, but slower to get the sort of numbers you need to have a convincing result. The paper that really convinced me, and should have convinced everybody back in 1976, that large is the way you want to be most of the time, is this paper by Richard Peto, who's here, and an all-star cast. It was communicated by Professor Sir Richard Dole, and you can read the conclusion. Given a given p-value, the result in a large study is more likely to be robust and repeatable than that same p-value in a smaller study. And Richard and colleagues did this in a very, very intuitive way, which I haven't seen taught a lot. Usually we show lots of sample size, power, calculations, etc. But basically, they showed very intuitively that if you just think of studies as a screening test for the truth, then the predictive value positive is going to be much more often high when the prevalence of the true answer is high than when the prevalence of the true answer is low, and the prevalence of the true answer is likely to be higher if you've done a big study. So that had a major influence on me thinking about how to get big sample sizes. And so we can be big in a number of different ways. If we're lucky, we have a sufficiently large study and we have a relative few of these. We can do meta-analysis of summary results from the many smaller studies. And again, Richard and colleagues have made major contributions to the statistics of meta-analysis. If we're really lucky, we can persuade people to give us the individual data, and we can do pooled analysis of the individual data, and that gives us more flexibility. But arguably, the field has been really contributed to mostly by meta-analysis. And in just thinking about some meta-analysis that I've been involved in, this was actually work that was the first grant I ever received. We tried to put together all of the major prospective studies that had information on diet and a variety of cancers. And so this was the sort of information you got on an individual basis, pretty much nothing significant. On an individual basis, the relative risks wander around. This is the relative risk for milk intake versus colorectal cancer. So on this side, it's protective. On this side, it's a risk factor. All studies except one seem to be on the side of protection, but none are individually convincing. When you put them together, there's a significant inverse association, no actual heterogeneity. And this fed into results like the World Cancer Research Fund report on diet and cancer. And subsequently, the big EPIC study that wasn't initially in the pooling project found exactly the same thing. And I'm delighted to say that I believe that in the Million Women study, with a large sample size, exactly the same thing. So the key is, in many ways, to try and get rid of the back and forth in the results and the heterogeneity of the results. I'm not going to claim that this is unconfounded necessarily. We've done collectively the best job we can. We can have a discussion about whether it's causal, but at least let's get away from the individual study of the day, gather all the data, and of course I'm bringing coals to Newcastle in saying this, in Oxford, that's been the home of so many large-scale pooling projects. So the trick here is to bring all the data together, do the state-of-the-art analysis, and then have the discussion about causality and confounding, rather than having that on the basis of the individual studies as they're published one at a time. But the problem still remains that that's a lot of work. It requires a lot of people to be doing a lot of work in different places. It often requires them to submit data to someone who's doing the pooling or meta-analysis before they're ready to publish it. That has all sorts of swings and roundabouts in terms of the diplomacy of conducting these large collaborative studies. It really would be nice if we had more large single studies that you'd be able to hang your hat on. And the reason we don't is that our technology really wasn't up to the task. Many of you remember the days when pretty much all studies had interviewers, and so the rate-limiting step was the number of people an interviewer could see per day in a hospital or in the community. The data then had to be key-punched, taken from the paper questionnaire and put into a computer format. Later we got into optical scanning of questionnaires, so we could actually ramp up the throughput and ramp up the sample sizes, but we were still often limited because particularly in studies like the Nurses' Health Study, Health Professionals Study, operating in a country like the United States, where we had to get the information from each case from a hospital across the nation, somebody had to spend a lot of time interpreting and coding that information. It took a lot of time to put all of this information together. And so you were limited by the number of people you could afford to pay to do this very, very labor-intensive work. And again, in the United States, with different jurisdictions, a very balkanized health system with many, many different hospitals and hospital systems, it's easy for people to sort of drift out of sight, particularly if they move geographically, but also within one city. They may move from one insurance company to another, one hospital system to another, and that greatly complicates the task of finding out what happens to people, even if they've given us information. So, of course, the foundational cohort goes back to Hill and Richard Doll on the right, who, just in thinking about this talk, it sort of does take the breath away that early in the 50s, when the state of the art was to do a case control study, or even just a case-only study, they had the vision that they could assess this question of smoking and lung cancer by doing a large prospective cohort study. And they were able to persuade 24,000 male doctors to give them information about smoking and a few other things. If you dig into the fine print here, they point out pretty early in the paper that the key to getting a high participation rate was to be short and simple. So this was starting to be bigger, but not very deep, because in order to get this number of people to answer a paper questionnaire, probably also in order to be able to cope with the information and key punch it and get it into computer format or card format in those days, you couldn't really afford to be asking extensive information. So how have we done in the years since? So this is on a log scale. There's the British Doctor Study on the left. It was a long time before anybody started to try and do prospective studies on scale. One of my former bosses, Frank Spicer, came here, worked with Richard Doll, went back to the United States and started the Nurses' Health Study, about 100,000 women. Substantially motivated by that, one of my mentors, Walt Willett, started the Nurses' Health Study 2 and the Health Professionals Follow-Up Study. You can kind of see a theme here. And so we had doctors, we had nurses, we had health professionals. Why? Well, because they were people who were used to answering the sort of information you wanted, and they were people that you could often track. Even if they moved their address, you could track them through medical registration or nursing registration or other means, at least until they retired. So those were large studies, a little over 100,000 people, collectively about 250,000 people. Then came along the EPIC study, and Elia Ribley is here. 500,000 people across 13 countries, a large number of countries in Europe, to assemble a very, very large cohort. China Kaduri came along, Zheng Ming and colleagues are here. And these studies had the wisdom to build the biobank in at the start and to operate in a way that the blood samples were available on everybody pretty much in the study, instead of trying to go back and getting them from a subset afterwards. And then after a little more gestation, the Million Women study is still the biggest single study that I'm aware of. Valerie Beryl is here. Jane Green and Jill Reeves and colleagues had the wisdom to again approach women with something relatively short and simple, but then work very hard to keep them in the study and expand the information by sending follow-up questionnaires to enrich the database. After that, UK Biobank, Rory Collins is the PI. This is the biggest single integrated study that has produced the most data so far. And we've got now the All of Us study in the United States, where they think they're going to get 1 million people, but we better wait and see, and that may take quite some time. So all of these studies have in common, initially, health professionals who could be tracked and followed moving into the general population, acquiring blood samples, but being as big as possible. And the latter studies all increasingly have been able to take advantage of the fact, including in China with the national health insurance system, the fact that the health system is making diagnoses, and increasingly the health system, with appropriate consent, is able to make those diagnoses for us. We don't have to make them for ourselves. We have to interpret the data, etc., but we don't actually have to go and get hospital records person by person. So that's a factor of log of twofold, going from 25,000 up to 1.3 million. Meanwhile, how's the rest of the world done in terms of sample sizes? So this is the CPU speed in our computers, about 10 million. Number of human base pairs we can sequence per US dollar. Pretty recent development, but over a relatively short period of time, less than 15 years, again, 10 million-fold increased productivity. And so the question I'm asking in many ways is, well, how can we not match this? That would give us mega studies of most of the people in the world at some point, but how can we increase our sample size and throughput while maintaining rigor and being able to make legitimate and justifiable conclusions in observational data? Why do we need this? Well, there's still many, many diseases for which we don't have much prospective data simply because they're not so common. We've got a lot of data about the major cancers, about heart disease, about diabetes, about some respiratory diseases. But once you get to the less common and middle incidence diseases, we're still trying to stitch it together by and large across multiple studies in a meta-analysis. So wouldn't it be nice to have a bigger platform to be able to get high quality data for those less common diseases? Of course, the personalized medicine revolution is teaching us that what we thought was one disease can be many diseases. And as we increasingly subdivide diseases, we hope to discover risk factors that we had previously lost or not found because we were looking at an average across a single ICD code or average entity. As we discover that there are different subtypes, then we find that our risk factors are differential for those subtypes, and we find some risk factors we hadn't found for some of the subtypes that weren't the major types of that disease. So how do we get larger populations under study? Well, we can continue to aggregate cases in multi-study consortia. That's certainly alive and well with genome-wide association studies and absolutely needs to continue. But I'd like us to think about how we could get even larger single cohort studies in multiple countries. And that clearly would involve a more efficient methods of measuring exposure through the digital means we now have, combined with the remote outcome assessment that the health system is now able to give. The biggest cohort I know of this point, if you can call it a cohort, is my colleagues at Harvard took all of the US Medicare data. They call it an open cohort of 61 million people, and by mapping their location, were able to layer on information they had about air pollution, and even as low as the scale of air pollution down to 6 parts per million, PM 2.5, the small particles that really get deep into the lung. They see a almost linear association with dose. There is no safe dose of air pollution. And if that's correct, it has substantial impact for the policy and regulations on the cleanliness of our air. We're a little behind the times here in the United Kingdom. So it is possible, without actually ever seeing a person or interviewing a person, to, on occasion, capture very, very large studies. But of course, they had limited information on confounding factors, etc. So this isn't the optimal way to do studies. One of the anxieties that people always had was, well, if we get this big data, are we going to be able to handle it and analyze it? So the fact is that you can do big data in two ways. You can have a lot of people, or increasingly you can have big data per person in the study. And as we had biomarkers, we got bigger data, but the omic data explosion in the last 10 years, not on huge numbers often, but on large numbers, has given us an enormous amount of data on a limited number of people. And this has been likened to drinking from the fire hose, almost an impossible task. But in fact, we've actually been remarkably successful in doing something that I think 20 years ago people were worried we wouldn't have the intellectual and analytic capacity to do. So in 2005, it was a big data per person. If you had a few hundred data points per study, 2006, the genome-wide association studies hit. Suddenly we had millions of data points per person. And for those of you who aren't immersed in the world of genome-wide association studies, this was the moment when we could take genetic variation across all 22 chromosomes and the sex chromosomes. We could run that in so-called SNP chips in large numbers of cases of a disease and controls, and we could see which points of the genome were either more common or less common in the group that had the disease. And the first challenge was, well, how do you even display or get your head around the data? This was early data on breast cancer. Each of those colors is a chromosome. Each of those points is a genetic variant. Believe it or not, there's 500,000 genetic variants here. Now we would be routinely estimating 7 or 8 million. But it proved possible to sort the wheat from the chaff, find the needle in the haystack. And so this, for instance, is the variant in the FGFR2 gene, which is still the common genetic variant with the strongest association with breast cancer. As we increase sample sizes, this was based on about 1,300 cases. We now have data based on about 80,000 cases. The amount of information we extracted increased. And just the essence of this slide is that starting about 5 years ago, we started running a SNP chip on more than 200,000 cases of a variety of cancers, more than 200,000 controls. And again, we're in the business of stitching this together from multiple studies, and we probably always will be for this sort of work. But it's now possible to take the 180 genetic variants that are robustly associated with breast cancer and ask a question for every woman in those studies. Has she inherited a larger share of the risk or adverse variants or a lesser share, a larger share of the protective variants? It's on a normal distribution. And so you can ask the question, well, if you're in the top 1%, that's the top line here of that distribution, what's your lifetime risk of breast cancer? If you're in the top 5%, that's the second line from the top, what's your lifetime risk of breast cancer? And so we can get now relative risks of about threefold, looking at women in the 95th percentile, the top 5% of risk versus the median. That's about sixfold if you look top 5% versus bottom 5%. So this more than outperforms the breast cancer risk prediction that we had on the basis of the known classical breast cancer risk factors. It's very, very robust. So this is unpublished work from the Breast Cancer Association Consortium. And so it just goes back to the individual studies that contributed to data, looked at the prospective studies there, and asked the question, well, if you look for one standard deviation of the variation in the polygenic risk score, the sum of all of the 180 variants, how robust is that estimate across studies? And it's extremely robust, and UK Biobank almost performs as well as the rest in terms of the risk prediction. So not the time or place to go into the question of what utility this brings, but it clearly is of potential utility if women are trying to make a decision if they're at high risk, whether they should take tamoxifen or raloxifene as for chemoprevention of breast cancer. If you're a decision maker and you're trying to work out, well, at what age would it be appropriate for a woman to start mammography? Well, you could argue that if this information was available, you might want to start a little younger for a woman who's at higher risk. It augments the best models we had on the known classical risk factors. And I won't talk about this, but it also identifies women who are at higher risk in whom the benefit of changing lifestyle to reduce breast cancer through lower alcohol intake, less weight gain postmenopausally, greater physical activity. Not so many women are on hormone replacement therapy, thanks to Valerie and others. But it identifies women in whom those particular lifestyle exposures might be particularly important. The sort of point of this really is to point out that now we've gone from large and shallow to large and incredibly deep. Because we have the genome, we can do the same thing for the metabolome. The microbiome is of great interest. Geographic information systems allow us to layer on anything that your place of residence or place of work might tell us. So we have the potential to do very, very large studies with relatively small amounts of a blood sample, relatively small amounts of DNA. Microbiome still requires a stool sample, and GIS just requires us to know what your residence is and track that through life. So the task then before us is, well, how are we going to be able to assemble these very large data sets on very large numbers of people? And so I'm calling this systems epidemiology, but it's really epidemiology of the system. And epidemiology in the system. A paper last year in New England Journal of Medicine was the most recent contribution to the long-running debate about oral contraceptives and breast cancer. That debate largely started here in Oxford. I think Martin Vessey's here, some of the work with the GP cohort, etc. Malcolm Pike, who was here, obviously contributed data while he was here and also in Southern California. The collaborative group, led by Valerie and others, showed that by and large, oral contraceptive use wasn't a major risk factor for women who had ceased taking oral contraceptives, but it did increase risk in younger women who were taking contraceptives. Fortunately, breast cancer is rare in younger women, so that's a very small absolute number of extra cases, but it's unambiguously there. In the Nurses' Health Study 2, we showed the same thing in a much smaller prospective study. But the publication here, Morch and colleagues, looked at the whole of Denmark. And they can look at the whole of Denmark, as we all know, Scandinavians are very, very highly surveilled, and the state knows a lot about everybody, and they've got different registers. So they know who's had a prescription and they give oral contraceptives by prescription. They certainly know who's had breast cancer in a different part of the system. They know who's had a child and at what age and how many. So they have a number of the key potentially confounding variables. And they saw the same thing, a 20% elevation in risk. Now, almost 20 years later, with a different spectrum of formulations of oral contraceptives that we'd sort of vaguely hoped would be not associated with breast cancer risk, but here we are, they still are. And to do this, they had a population of 1.8 million women in the right age groups. Large study, but now essentially nationwide. A very wise editorialist, that'd be me, managed to persuade the New England Journal that really only wanted some expert comment about oral contraceptives and breast cancer and didn't want kind of musing on the side about what this meant from epidemiology. But I fought to get this paragraph in at the end. The study has exemplified the opportunities to use population-wide, quote, big data approaches to evaluate very important issues at low cost. Investigators in countries that have universal access to healthcare and those who have community agreement for the linkage of various databases, very important, are better able to conduct this research. And that's why I'm here in Oxford. So how are we going to do this? Well, the classic way we do it is to essentially treat the system and research studies as discrete. There's a lot of good reasons for that. But we get information about cases and controls or people in our prospective study. Increasingly in the UK, you can pull information out of the HES records and NHS Digital, and maybe even the GP records at some point in the future. Some of that will have some measurements. If you've had your height and weight measured at your GP, maybe that's accessible. But by and large, we treat these as discrete research studies, and we impact the system and society through a fairly complex system which has lots of useful checks and balances. We're not making recommendations based on yesterday's Guardian headline and changing our mind tomorrow. We have committees and experts that make policy, but it can be a very, very long time. And part of that is because the worlds of research and the worlds of policy and the worlds of practice are often quite different. What about if we really moved our studies into and they were of the system? So we're already getting measurements, diagnoses, the cases and controls. They all have a healthcare provider. Could we do our research studies and speed up the translational potential a little faster? Well, the problem is actually it's not so easy because by and large we're missing the exposures. We still have to go and interview, do a questionnaire to get the information that we need. Even in the CPRD, the collaborative study of, I think it's 300 GP practices, they've got state-of-the-art information about prescription medications and all of the things that go on at the GP's office and outcome, but very little information about lifestyle and environment. So why is that? Well, I think this is what my terrific GP actually knows about me. This is the form, or a version of the form that I filled out. Current occupation, ethnicity, past history of some significant diseases, very crude family history. Am I a never past or current smoker? Alcohol, am I a binge drinker? And that's it. If I was a woman, there's a question about contraception, last pap smear, have you had a hysterectomy, when was your last mammogram? So really procedurally related questions. That take about 5 minutes to complete. Imagine if everybody who went to their GP at some point filled out a version of the UK Biobank questionnaire. On average, it takes about 30 minutes, but it's been put together, carefully thought through. We'd have detailed smoking, detailed alcohol, much more detailed family history. We'd also have things like physical activity, diet, sleep. It still says in the textbooks that my GP is supposed to know this stuff. This is all part of a complete history. But of course, nobody has the time in a 10-minute consultation where there's usually a presenting complaint to be dealt with or a chronic condition to be managed. Nobody has the time to do this, and the GP is the last person in the world who should be functioning as a data entry clerk. GPs are already feeling that they're doing too much of that with the electronic medical record, and my colleagues in the US are feeling that times 10. But if we could get people to do this, and we've now got the UKB questionnaire in sort of beta test version, that's a tablet on the left, that's a mobile phone on the right. Take my word for it, it's actually quite easy to read and understand. And of course, critically, we would need consent for research. I would argue that this stuff would be useful in my medical record, and we've got a subgroup who are trying to establish, well, what information would be useful in the medical record as opposed to just clutter up the medical record. But if you give me consent for research, then we could get much larger studies in conjunction with the fabulous system for now ascertaining disease outcomes. So of course the problem with all of this, there's intense skepticism about whether people give us the right sort of information. People lie, people exaggerate, people underestimate. As epidemiologists, maybe just as human beings, we're taught to be very, very skeptical of the information that we routinely get. In some cases, people are setting world records for their inability to tell the truth. But it is important to really sort of hold this information up, and on average, do we get information that is sufficiently reliable and sufficiently valid to give us reproducible information. So here's an example from the Danish Cancer Diet and Health Study. No surprise that number of drinks per day, linear association in men and women with the risk of alcoholic liver cirrhosis. Might be some circularity in that in terms of whose cirrhosis gets diagnosed as alcoholic or not. But the information on alcohol consumption is good enough. I mean, one of the studies that you've done here, alcohol and breast cancer, again, a very linear and reproducible association. The large breast body mass index and mortality collaboration from a couple of years ago, very large number of studies where people had meticulously measured weight, measured height, got a very accurate estimate of body mass index. And here's the relation of BMI, uncorrected for provided confounders, with mortality. So it sort of tells you that old adage, you can't be too thin, is not correct. But the sweet spot is less than overweight, and you don't want to be obese. But let's now take the people who we can't trust to tell us their weight and their height and look at that information. Almost exactly the same association across a large number of studies, across a large number of countries. People exaggerate or overestimate how much physical activity they get. So here's the pooled analysis of the dose-response relationship between increasing meds per week, increasing physical activity, and mortality. A little bit of a kick up at the end, which is a bit of a surprise, but not many people here. But essentially, the more you exercise, the less likely you are to die. Again, we can talk about whether that's causal or confounded, or there's reverse causation. Here's the same information from the accelerometer in the Women's Health Initiative, essentially using a gizmo that detects how much activity you do, essentially the same association. Emerging data from UKB, association is stronger using the accelerometer, but still there in the self-reported data. So by and large, self-reported data gives us consistent associations if the studies are large enough, and we're not dealing with the sort of ping-pong match of small studies. If we do have gold standard data, like the accelerometer, then we can correct for that error using statistical techniques. If it's random, we can correct for it using regression dilution. We can also correct for systematic bias. So we always want to build into our studies the most objective measures we can get. Of course, the problem is self-reported data don't give us any information about things that you and I don't know about. So we don't, by and large, know about our genome, our metabolome, our microbiome, etc. So those are situations to get that data where there's no option to self-report. You have to go and get the sample and do the work. So we need to blend what can be reported reasonably reliably with what cannot, and we always need to be skeptical, but we don't need to throw the baby entirely out with the bathwater, because by and large the questionnaire-based, interview-based assessments that we have done a pretty good job if the studies are large enough and we're not constantly dealing with false positive or false negative smaller studies. So a number of us have been brainstorming about how this might work in the UK. Fiona Reddington's here from CRUK, John Bell and others. For a slightly different reason, we need another blood cohort, because if we're going to be able to assess what are fairly exciting new cancer detection methods, then we'll need more people to give more blood, but we'll also need the blood stored in a different way than we have in the past. So we think, well, maybe we could get about 1 million people to do that. And my contribution here is to say, well, if we're in the business of asking people, and a lot of people are going to say, no, I don't want to give a blood sample, or that's a hassle, will they fill out the UKB-style questionnaire? Then we can go back to them and say, well, will you spit in this cup? Much easier than giving a blood sample, but we can get equally good genomic information out of mouthwash samples as out of blood samples. And imagine if this was integrated with many of the other fabulous studies and networks that are currently ongoing, again, notably Biobank, but also the other studies, and really informing the system and of the system in a more rapid turnaround, definitely based in the system at low cost, so we can get information directly from patients, some of which may be actually useful to their medical care, some of which may be of research interest only, but the UK would be the place to do this. I think the only other place in the world you could do it at scale is China. You can't do it in the US because the system is too balkanized and fragmented, and people move from setting to setting, and it's almost impossible to get uniform outcome information. So I'm going to finish by getting even more over the top and ambitious. Can we really establish a virtuous cycle between epidemiology and the people? And our current practice is something like this: ask, but don't tell. If you go to a lot of time and expense asking somebody about their lifestyle, the last thing you want to do is to have them go and change their lifestyle because you give them some advice about maybe they could do a bit better on some aspect of it. We don't want to give people the incentive to lie, so as Richard has pointed out to me, if I'm asked whether I'm a binge drinker and I know that information will go to my GP, well, I've got an incentive to say I'm not a binge drinker because I just don't want to be lectured at. Mainly and principally, we don't want to be responsible for the sort of feedback or advice, particularly if it's some of the genomic data that we by no means fully understand. Well, I would argue, if we actually were able to, just with a simple communication, move some of these risky behaviors in a better direction, we should be so lucky. I think we overestimate our ability to change behavior, but any behavior we do change in the right direction is of benefit to people in the studies and the system. We could always give the option that the information won't go into the EMR, so I won't be grilled by my GP at the next visit. And this is a bit controversial, but if we give people more access to this information that we don't fully understand, we should be able to deal with some of that, hopefully on a legal basis, with the right consent form and the right disclaimers about the use of that information. So in a learning health system, epidemiology would be thoroughly integrated in the same way as general practice and surgery and the medical professions are. We'd be getting more of the exposures in the electronic medical record at the GP's office. Some of that would have an impact on care. That would enable us to give prevention advice. People don't have to take the advice. That might lead to some reduction in disease risk. Of course, diseases are always going to happen. So we need to be able to ascertain what the treatments are, hopefully examine what the factors are in reducing the adverse sequelae of the treatments and the disease, and continue to refine that so in 10 years' time, we ask an even better set of questions that are more focused, maybe more personalized, but all we're asking is half an hour of all of you every 5 or 10 years. I don't know about you, but you can spend half an hour on the bus getting to the GP. You can spend half an hour at the GP's office watching people go in and out. So half an hour investment in one's own health might be an attractive value proposition for large numbers of people in the UK. So to summarize, we're in the business of horses for courses. Small epidemiology for the right question still absolutely works and gives us the right answers. Most of the time, because we're dealing with smaller relative risks and complexity, we need large sample sizes. New technologies allow us to get all sorts of novel measures of exposure. A system like the National Health Service enables us to obtain almost complete follow-up as long as it's not cut into pieces and privatized. Epidemiology could be part of the health system as opposed to this independent, rather academic activity. Giving people advice based on their own data can actually be an object of study. We have the computational means at the Big Data Institute and other places to cope with massive data sets. The challenge is to gather the data, and the challenge is to agree on what would be informed consent in order to be able to use it for research purposes. The technical way now exists to do this at scale. The question is, do we have the will? So with that, I'd like to make some acknowledgements. A lot of the early data, I'd have to acknowledge infinite cast of characters. So I just chose this slide, one of the most recent big studies that some people here were involved in, but many of my colleagues at the Harvard School of Public Health, at the Brigham and Women's Hospital, and other parts of the world were involved in. None of this happens without an enormous amount of work by a lot of people at many, many different institutions. And that's one epidemiologic constant that isn't going to change. And then finally, I'd like to thank members of my family for coming. Two very special acknowledgements and thank yous. This is my daughter and my wife. My daughter Claire Hunter, my wife Leona Hunter, Leona Sampson Hunter. This was actually at the Women's March last year, and it was really only possible for me to have the privilege and the honor of coming to Oxford to be the Richard Dole Professor because they agreed. Claire had done the right thing. She'd graduated from college, and I know you don't see us so much, but I'm just very grateful that you're here today, and I'm very grateful that we're still in daily touch by text and other means. And my wife, a professor at the Massachusetts Institute of Technology, graciously agreed to do something that you got to be crazy to do at our age, which is pick up sticks from a place where you'd been for a long time and were very, very happy and comfortable, but come to a place where there's just fabulous possibilities. And so I'd like to acknowledge her piece in this move across the Atlantic, and thank her for her permission to come and talk to you today. Great. Thank you.
Please rise.